Oh, tell us a little bit about Britton. You've known him for a really long time now.
Yes, we met, I think, when he was about 3 months old, when he came in very sick with a leaky mitral valve and two holes in his heart, one between the upper chambers and one between the lower chambers. And so we took him to the operating room, repaired his mitral valve, closed both holes, and he did well after that. We knew at that time that he had an abnormal aortic valve, but that wasn't really bothering him that much. And it was only, as in the last 2 or 3 years that the valve began to leak some more, but it wasn't bad enough to schedule him for aortic valve replacement at this point in time until he got his aortic valve infected, which destroyed the valve and also caused other problems, sort of an abscess cavity next to the aortic valve, which destroyed part of the annulus, or a portion of the valve itself. So it made the valve leak much worse, and so his infection cleared with antibiotics, but after that time he had a terribly leaky aortic valve and it needed to be replaced.
When somebody has a terribly leaky aortic valve, what does that mean for their state of being?
Well, their heart has to work much harder to get blood to the rest of their body, because the left side of the heart pumps the blood out, and then half of it runs back down into the left ventricle, backwards into the left ventricle again. So it has to pump the blood twice in order to get it to where it needs to go. And so it really makes the heart work hard, and the heart begins to dilate and begins to fail if you don't repair it. So his was bad enough that his left ventricle was beginning to dilate, which is the early sign of heart failure. Oh, well, it's a variable length of time, and it depends on the age of the patient. Sometimes it's not tolerated very well at all. He was getting along reasonably well, but we wanted to postpone his operation until we were sure that his infection had cleared. But one of the studies indicated that he had something else going on besides a leaky aortic valve, and we weren't quite sure what that was, and it turned out to be there was this egg-shaped cavity on the backside of his aortic valve, where the infection had eaten through the wall of his aorta and valve into the space behind his aorta. But we weren't quite sure what that was all about until we actually got in the operating room, and then it became clear what the problem was.
The staph infection.
The staph infection, that's correct.
So this last procedure, I know that it was going to happen eventually.
Oh, yes.
Well, a replacement was going to happen
Right.
eventually.
Right.
Then you guys, it became emergent.
Right.
And you decided to do the Ross procedure. Can you tell me a little bit about what that is?
Well, a Ross procedure is where we actually do an auto transplant. We actually take the pulmonary valve out of the right side of the heart, which is typically the same size and have as 3 leaflets like a normal aortic valve should have. Britton only had 2 leaflets to his valve because it's been abnormal since before birth. But it was functional up until the time a few years before he got the infection, and the infection just destroyed it. So that, but anyway, we take the pulmonary valve. After we remove the aortic valve and clean up that area, we take the pulmonary valve and put it over into the aortic position and reimplant the coronary arteries, which come off just above the valve, into the new valve, and then hook it back up to the aorta. And then we replace his pulmonary valve with a cadaver valve from a heart that we didn't need for transplantation or wasn't the right size or whatever. And so it's a human valve that's been treated so that the body doesn't reject it. So it's probably, the pulmonary valve is the most expensive valve that can be purchased, because of although God made it, had to have certain treatments to make it acceptable for us to use in the operating room.
So will he be on anti-rejection drug?
Not at all, not at all, because once it's undergone this treatment, you don't reject it. So, and it has the potential of lasting him forever, because we put a larger one in than he actually needed at this point, a fully adult-sized valve, just so that it'll be big enough when he's older, and hopefully it'll be the only pulmonary valve that he'll ever need. And with a living valve now in his aortic position that's living as he does, it'll grow as he grows. And hopefully that'll be the only aortic valve replacement that he'll need in his lifetime. I can't guarantee him that, but we've been doing the Ross operation here at Riley and at IU for 25 years. And most of the ones that we've done are still functioning, over 90% are still functioning normal. Now, will they last another 25 years? Well, every indication is that they will last that long.
How many have you done in 25 years?
Oh, it's above 350. There's about, 40% of them have been done in children, but even more so in adults over the age of 20. So it's a good operation for a young adult who we think has greater than a 20-year life expectancy, because most of the tissue valves, PIG valves or pericardial valves that we put in a patient have a life of about 10, maybe 15 years, rarely 20 years. So the Ross valve can last, forever because it's a living valve. And it's the only valve replacement that you can do in a patient that puts them back on the normal life expectancy curve. No other valve replacement that you can do, mechanical, other kinds of tissue, put you back on a normal life expectancy curve. So that's obviously what we want for a child who we think will have a long life expectancy.
From a lower technicality viewpoint here, I think the beauty of this is that the kid can go back to playing what he wants to play.
Yeah, he can go back to doing anything he wants to do.
Why is
Yeah.
that?
Well, just because it's a living valve. It'll tolerate, normal pressures and all. It takes a few months for the pulmonary valve, which has been used to low pressures, to sort of adapt to the high pressure side of the heart, the left side of the heart. And so we like them not to be hypertensive or not to have a high blood pressure. So we try to keep their blood pressure in the normal range for the first 2 or 3 months. By that time, the pulmonary valve adapts to the high pressure left side of the heart, and it'll tolerate anything. So the only thing we caution them about doing is power lifting. I didn't want him to try to lift 200 pounds over his head or whatever, because that puts an undue stress on all heart valves, and probably not a good idea.
So no blood thinners, right?
No blood thinners, no.
Why don't you have to use blood thinners?
Because it's tissue valve, it's its own valve, and it's a living valve, so it doesn't have a tendency to clot at all. So that's one of the other beauties of the Ross operation. So you don't have to take any blood thinners, and there's a potential that it'll be the only heart valve that he'll ever need.
And my last question, when you listened to his heart last week, what did you think?
Sounds like a normal heart for the first time in his life. His heart has always been noisy because of the bicuspid valve. We could hear it leaking even before he got the valve infection. So it just sounds like a normal heart, just like everybody else. So.